So thank you, Dr. Avnish, for inviting me to be part of this session. So I'll be talking about a case of intraocular cysticercosis, a submacular one. All of us know that cysticercosis is a parasitic infestation which is caused by the larva form of the Cystotaenia solium, and it apart from its effect on the eyes, it greatly affects the central nervous system in form of the neurocysticercosis. And in the eye, it can lead to various lesions like a subconjunctival cyst, cyst floating in the anterior chamber, intravitreal cyst, or a subretinal cyst, as we would be talking in this case.
Segment evaluation was normal. Posterior segment revealed a yellowish subretinal lesion involving the fovea. Certain relevant investigations were.
So the CT scan of the brain was also done, which was unremarkable, and a neurology consent was also sought before going ahead with the surgery.
Advised to the patient. The OCT revealed a large hyporeflective cystic lesion along with a hyperreflective wall with something that looked like a scolex attached to the wall of the cyst. Rest of the investigations were unremarkable. So, clinical diagnosis of subretinal cysticercosis was made. Patient was put on oral steroids and vitrectomy was planned. 25 gauge 3 ports were made. Core vitrectomy was performed, and if you notice keenly, the classical undulating movements can be observed here. PVD induction was tried first without triamcinolone. Then triamcinolone assisted PVD induction was successfully done and a complete vitrectomy was performed. After the removal of vitreous, we could see a macular hole that had also.
So just post the PVD induction, we could see that large size macular hole had also developed.
A small retinotomy was made at the edge of the cyst to access the subretinal space. Through this retinotomy, active extrusion was used to bring out the cyst in toto. The macular hole was more apparent at this stage. The highly compressible nature of the cyst can be appreciated here as it is removed totally through this small retinotomy. This prevents any collateral damage to the surrounding retina while its removal. Then the cyst was eaten up at high suction and high cut rate with the help of the cutter. Fluid air exchange was performed. The subretinal inflammatory debris and the SRF were carefully removed from the retinotomy that was made earlier. The retinotomy site was then lasered with very light burns in a single row. SF6 gas was then injected, and after that the patient was advised to maintain prone position for another 1 week. So we got good outcomes after the surgery, a vision of 618, and the hole was closed.
Thank you so
much. Excellent surgery, Dr. DIVA, and very meticulously done, and having a thorough workup is most important before actually going in for surgery. One thing we need to discuss is whether actually lasering that area would have been done, or whether we could have just done an FAX. And secondly, actually, if there is a bigger hole like this, which is very much in the posterior pole and in the macula, whether doing an ILM peel and just keeping it over that would have been an option.
So the retinotomy was, I felt it was a bit bigger on the bigger side, so I thought it would be prudent to laser it. And I felt that the macula that was looked quite fragile. So an ILM peeling or something of that sort would have been very difficult in this situation. So, but the hole closed well post surgery. So, and it was not due to any tangential traction or anything. So I think we would get results without ILM peeling in this.
Dr. Bhavik, your take on this?
So the preoperative cyst and intraoperative cyst was the same location.
Yeah.
So most likely the cyst was dead. That is what you think?
No,
because
it
normally
was
they keep on
because
migrating. Because what
the
we see in the OPD and when you plan for surgery, the cyst may not be present in the same level. Sometimes it can go from subretinal to the vitreous space.
because the gap between the first, because it was a referred case, so it's almost within 24 hours we had operated the case.
Okay.
So, but almost, yeah, it was on the same location.
Yeah. So only
It
point
was
I
not
would-
dead because we could see the movements and all. So
Dr. Kumar, you want to add?
I was just wondering about the macular hole that was present, which I guess, yeah, as you said, that the ILM peeling would not probably have been the best idea. But what do you think is the mechanism here of the closure of the hole? Because the hole probably was created after the PVD because we could not see it on the OCT. So, I mean, what probably is just the closure mechanism here? Did the gas help or?
the hole, I think, was formed with the jet of the transcendent. Maybe I think that was the mechanism of its formation, because when I hit the jet, it was, I could see at that moment. I'm not sure whether it was due to the PVD or because of the jet of the transcendent.
So I feel the reason for hole occurrence because it was already tented for a very long time and it would have got thinned out. And when we are inducing a PVD, that's the most thinnest part of the retina, and then that has just yielded off. And as you could see, because of the PVD, there is an anterior-posterior traction, and because of that itself, like that's what the mechanism of hole formation. And the vitreous usually in young patients are attached at the fovea also. So means I would have tried to do like a donut vitrectomy. Obviously, all that retrospectively we can think and then try to do whatever is possible. He did his best, and the results are very good. One more thing which I would have wanted to do was to peel ILM and not to do laser at the site of that drainage retinotomy, because once you peel the ILM, the chance of the detachment are very low. And as you could see that after the laser, because the retina gets also thinned out, we could have added laser post-op with like a focal barrage kind of a little more control, because as you could see that whenever we use a laser which is intra-op, obviously the distance and the power and all is completely different, the scarring is different, but fantastic.
So even in submacular hemorrhages, we see that when you go and operate, there is a tendency for the hole to form, right? So because of thinning which happens, so a bit of thing.
So one more thing, whether we would have just left it with a fluid gas exchange rather than putting in a gas for the stop.
Choice is very personal, but obviously young patients we are thinking more into, so that's choice.
And in case, like if we actually are taking the cyst out and if it actually kind of bursts, so then it's difficult to actually manage that. So the thing is, the way we actually went very it should not burst. This is what the idea is.
So I have seen Dr. Mahesh operating such cases by doing a like not such posterior, but near to equator and just posterior also to remove it transclerally.
Right.
So not even to do a vitrectomy. So we have seen him doing all that, but yes, we have seen him doing vitrectomy also. Even if the cyst ruptures, the only thing which in the previous literature has been mentioned is a significant vitritis post-op. But because right now all the vitrectomy systems are so good that all the whatever the coagulum, once it gets dispersed, it's washed out also easily. So that is not expected. Even if it ruptures, it doesn't have any issues.
You don't tend to see the vitritis.
That's true. Yeah.
Rajesh, any comments pertaining to this case about what we could have done in a better way? Because we're all learning here. Or any alternative approaches?
I would have pretty much done the same way. Whether we could have peeled the ILM and left it to close the retinotomy to drain to remove the cyst, I would have probably done the laser because there is some amount of inflammation in the area of the retinotomy because the cyst was there, and there is usually some amount of inflammatory debris there as well. So that retinotomy I would have probably lasered, and ILM, yes, of course, for the macular hole I would have peeled it and left it like that. You could see that white ring around the cyst indicating there was an inflammatory material. So I would have probably lasered it as well.
Thank you.
Thank you, sir.